Hi, welcome to Oral Bites podcast. Today we're going to talk a little bit about antibiotics. I think it's going to be the first in a series of podcasts that we're going to run. Get some opinions on how we're using them in dentistry, what the guidance is in terms of sort of implants and extractions, and maybe some other things that we might be prescribing antibiotics for. Or why we shouldn't be prescribing antibiotics, what procedures we might not be using them for. Sort of touch on some of the guidelines that are out there, and really kind of get some guidance to make us feel comfortable that we're doing the right thing for our patients. And that's ultimately what we want to do. Make sure that we're looking after the people that we're looking after, essentially, and doing right by them. And trying to make sure they're getting the right kind of care, the right kind of treatment that's going to not cause them any harm or put them at any risk, or put them, at minimal risk. Essentially, that's what we're trying to achieve, obviously. So where do we start? Well, we're looking at sort of avoiding something called infective endocarditis, which is it's a rare, thankfully rare, issue where there's an infection of the heart valves, and this can be attributed to bacteria entering the bloodstream. And how those bacteria get into the bloodstream is debatable. Some people feel that it is potentially happens when a tooth is extracted, or when we do some invasive dental procedures. If you're on one side of the fence, and if you're on the other side of the fence, you may feel that that's not the case, and that there are other causes of the bacteria entering the bloodstream and causing this infective endocarditis. And I guess there are people in the middle. So we have these essentially high-risk patients. Some of them may have artificial heart valves, some of them may have congenital heart defects. Patients may have a history of infective endocarditis, and we need to know whether we need to give antibiotics before our procedures where we're being invasive, such as taking a tooth out or placing an implant, for instance. When we, as dentists, sort of look at our guidance sort of comes from NICE sometimes. So this is the UK-based guidance that we're looking at. And back in 2008, NICE sort of changed their stance on antibiotics and prophylactic antibiotics. And their kind of view was to reduce the reactions and the overprescriptions of antibiotics in dentistry, and obviously in other areas of the medical field. But if we focus on the dental side of things, so their stance of routine antibiotics was essentially that there was, at the time, insufficient evidence to benefit patients, which differed slightly to the US and certain EU countries. So we have to base how we treat our patients on the guidance and on the evidence. But as the term says, it's guidance. So we're guided as to how we look after our patients. And this guidance back in 2008 kind of suggested that there were some changes, and we therefore weren't prescribing, in certain situations, antibiotics for the patients that we had been prescribing antibiotics for in the past, for certain treatments. I'm sorry to be a little bit vague on that, but what I'm basically saying is there was a change in tact back in 2008, and NICE essentially changed their guidance. And some of us thought that was a good thing, and in certain circumstances it certainly was, and some of us resisted that. And there is the conflict, because what's happening now is we are in an area of this grey where patients are coming to us with cardiac issues, and the cardiologists are sort of expecting us to prescribe antibiotics for the patients. for certain conditions. And this is sort of potentially conflicting, or it might not marry up with the guidance that we're being given. So there are various different viewpoints coming in, and it's how we untangle that and to make sure that we look after our patients and do the right thing by them. And whose guidance do we kind of follow? So with NICE guidance, who, as we mentioned, our initial concerns were the overuse of antibiotics and the sort of the anaphylaxis coming into it, which was also backed up by a Swedish study here in 2022, which sort of also goes with the NICE guidance, and said that they found no increase in infective endocarditis after reducing antibiotics, which kind of maybe muddies the waters a little bit for us. But now a more recent paper in 2024 from the University of Sheffield, so again, we're coming back into the UK, certainly is challenging NICE's 2008 stance, and saying that there is certainly some statistics that go against that Swedish paper and potentially may go not against NICE guidance, but certainly maybe put it into a review, which is possibly needed. And I've got the stats here. So without antibiotics, there is a 1 in 1,000 high risk patients developing infective endocarditis after dental procedures. And with antibiotics, that risk drops to 1 in 3,333. So certainly there's a change in the risk. Whether you deem that a big change or not is entirely up to you. And then when we look at extraction specifically, that risk is slashed from 1 in 100. So 1 person in 100 developing infective endocarditis, high risk, remember, compared to 1 in 1,000. So a tenfold change. So, according to the Professor Martin Thornhill, we're kind of seen as a bit of an outlier when it comes to this sort of thing. So I think we should probably explore this a little bit more detail in later on in some more of the podcasts. Get some hosts on, let's get talking about it. Please add some comments. October 2024, NICE updated its stance, shall we say. Still following through that routine prophylaxis is not recommended, but it points and it links to the Scottish Dental Clinical Effectiveness Programme, which is a very good programme. So if you have a little look at that, the SDCEP and their guidelines, which are a really well written document, if you ask me, and sort of show you the pathway of your selection criteria and maybe the discussions that you have with your patients. So your analysis, your discussions, liaising with the cardiologist, what the cardiologist has said, what the patient interactions are, and then what you should maybe be having with your conversations with the patients, which ones are high risk, for instance, as well. So I think that's at least some way forward, and it looks like, looking at the recent website, that NICE are going to review their guidance and maybe come up with a bit more of a clearer stance for us. What are your thoughts? Where do you sit with this? I think it is time that we had some clear guidance. We want to know where we stand with things. We want to be able to look after our patients. We need some good, strong evidence to tell us what is the right thing to do, so that there isn't this grey area for us. Let me know.